Good afternoon. This is Dr. Douglas Beck with the Hearing Matters podcast, and I am here today with my friend and associate and colleague, Dr. Christina Roup. Dr. Roup holds a BA and an MA in communicative disorders from California State University at Long Beach, and her PhD is in communicative disorders from the University of Wisconsin at Madison. Dr. Roup is an associate professor at The Ohio State University. Her research focuses on the effects of aging, traumatic brain injury, and functional hearing difficulties on binaural auditory processing. Her secondary research examines the benefits of low gain amplification for adults with functional hearing difficulties who have normal pure tone thresholds. Dr. Root, welcome. Good to see you again.
Good to see you again. Thank you for having me.
My pleasure indeed. Let's talk about people who have normal thresholds, yet they're having difficulty hearing a noise or classically hearing difficulty, and they don't show any hearing loss. What do you do?
I think you pay attention to their complaints, right? So, one of the things that I really encourage is the use of standardized questionnaires or the self report from your patient. Listen to their complaints
Yeah,
because the pure tone audiogram we know does not correlate well with self perception. So,
and
that's
I'm
the
so
first
glad.
step.
Yeah, I'm so glad you said that. We'll come back to audiograms. Tell me step two.
Step two is do more than just test pure tone thresholds. So I think we need to be testing speech and noise. And I know you're an advocate for that as well. So listen to their complaints and test, use our test measures that directly address their complaints. And then I think the other thing we can do is go beyond 8,000 hertz on our pure tone audiometry, right? So
Yes.
there's a wealth of evidence that's demonstrating that extended high frequency hearing really matters when it comes to speech and noise deficits.
So if I were going to be snarky, I would say, well, this must be a new finding that extended high frequencies matter because, gosh, we've only known about that since World War II. Just,
Exactly.
probably 5% of us do it, right? And it's so important because when you think about the eighth nerve, the auditory vestibular nerve going to the brainstem, it is tonotopically or topographically oriented. So the extreme high frequencies are on the outside. And many people would say that as degradation occurs over time through noise-induced hearing loss, through presbycusis, through ototoxic drugs, through traumatic brain injury, which I know you've studied as well, through these things, the first damage point in the auditory system is going to be those extended high frequency neurons.
Exactly. Exactly. And I think what we may see if we continue to do this, and I think we should, is that if you have that patient who has pure tone thresholds within our classically defined normal
Yeah.
range, if you keep going and measure outside that range, you're going to see threshold elevation in those extended high frequencies. And I think that's, the research has shown that from the past, but also from the very recent past as well.
I think this is so important. We just did a podcast on extended high frequencies, and we'll put a link to that in the web version of this one because it is such an important topic. And you'll see that so many of the patients with normal thresholds, between 250 and 8K, will have extended high frequency difficulty. And they may complain that they can't understand speech and noise. They may complain about tinnitus. They may complain about a million things and we're not catching it because we're not testing for it. You don't know what you don't test. There's a wonderful article that came out, I think, since you and I last spoke. This is by Dr. Charles Lieberman. Are you familiar with this? Do you know where I'm going? Okay. So noise damage and hidden hearing loss, cochlear synaptopathy in animals and humans. And what Dr. Lieberman says is when thinking about sensory neural hearing loss, it's very important to differentiate problems with audibility, that's, the ability to hear, from problems with intelligibility, the ability to extract meaning. And he says for decades, it was believed that hair cells were the primary target of damage in most forms of sensory neural hearing loss, and that auditory nerve fibers degenerated mainly as a secondary effect, if and only if the hair cells were already destroyed. These ideas were challenged when our lab, meaning his lab, in both noise-induced and age-related hearing loss of mice, the most vulnerable elements in the inner ear were not the hair cells, but the synaptic connections between hair cells and auditory nerve fibers. And that type of synaptopathy could silence 50% of the neurons without hair cells changing thresholds.
Powerful, powerful words,
So how do we
right?
get the profession to take this seriously and do something about it?
If I had the answer to that, we would both be millionaires, wouldn't we?
Well, at least
Um,
you would be, yeah. I mean, we're in the stall mode. There's a couple of things here to unpack. Number one, now this is a good time to go back to pure tones. Tell me your perspective on pure tones being what we all refer to, not you and I, but most of us refer to audiograms as the gold standard of hearing measuring. What's on your audiogram. And I'd like you to speak about that and the categories of convenience.
I love that phrase that you use, categories of convenience, or the traditional classification for degree of hearing loss, right? So if we go back in time, we know that normal hearing has been classified as thresholds between 0 and 25 dBHL. But many of us argue that that is too wide of a range, right?
Yeah.
That we really need to tighten that up. And there's numerous researchers, professionals who are arguing for that, right? It's not just you and I.
Oh, and in
But that
1929, almost 100 years ago, Fletcher showed 15 was the outer limits of normal. But I
exactly.
but I digress. Please continue.
No, you hit the nail right on the head, right? That 15 dB demarcation is a much better place to separate quote unquote normal hearing from threshold elevation or impaired hearing. And I think that is a great place for us to, what's a good way to say that? That is a really, for us to continue to advocate for that change
So,
in,
so yeah, I absolutely 100%. So let me ask you, if you were empowered by AAA, ASHA, IHS, ADA, all of our acronyms to design a perfect audiogram, what should the categories be? If you would work me through like normal, slight, mild, moderate, severe, profound, as you see, because Blaze Delfino and I at the Hearing Matters podcast, we have constructed what we think is kind of an ideal audiogram that we're absolutely willing to have people just download it and use it and take it for free. But we're not an academic institution; we're a podcast. So tell me your preferences. How would you define each of these categories?
yeah, I think if you consider normal hearing 0 to 15 dBHL, I think that's a great place to start. I think we already have that category of slight hearing loss that has been
Yep.
introduced, but it was classified as only use for children, right? And I think if we go away from that, we could say that is still a slight hearing loss for anybody, right? It doesn't
And
have to be just children. It's
yeah,
tough because I will just say that these words that we use to classify these ranges can be really misleading, right?
yeah.
Slight and mild. It's like having a mild traumatic brain injury. It's not mild for the person who has it, right? Mild hearing loss. Is it mild for that person?
This is such a great point. So I almost want to throw away these terminologies entirely.
No.
And with all due respect to my colleagues at Johns Hopkins, I'm not a fan of the hearing numbers. Problem with that, to me, is that they only represent loudness. They don't tell you anything about processing or clarity or
Right.
speech and noise or hearing difficulty. They're just measuring pure tones. Now, the thing about that, two things. Number one, you only need 50% of the auditory fibers intact to press the button when you hear the beep. So
Right.
you can have very significant damage and have 0 dB thresholds or 2, 3, 4, 5, 6, 7, 8, 9, 10, etc. So that's one thing. And then the other thing is that people can handle two numbers. They know their blood pressure is 115 over 80. They know vision is 20/20. They know they have 32 teeth in one mouth. That's almost two. But I don't think that it's going too far if we design a very, very simple number. Now, here's the other thing that I don't like about the categories. If we said 15 to 30 is slight, then that's based on a pure tone average, whether it's three
Right.
frequency or four. And
Right.
many of us use four frequencies, many of us use
Right.
three. And it depends, do you use interoctaves? So none of these numbers are necessarily repeatable universally. And then you look at the World Health Organization numbers on hearing loss, and they're very, very different. I'm not saying right or wrong, but a very different mindset for a very different purpose. And so I almost wonder if the simplest thing to do is just, we know that hearing loss is decibels. There's rarely a patient who can tell you what a decibel is, and we don't really have the time to teach that class to a patient. And I don't mean that disrespectfully. It's just, it's not part of their life, right? So what if we just said, you know what, for the purpose of patients, why don't we have 0 to 100%, just whatever the
Mhm.
dB pure tone average is,
Mhm.
make that a percent. Patient says, well, I have a 45 dB loss, or I have a 45%. Okay, good enough for a patient, isn't it? I mean, would that add more confusion, or does that
Yeah, that's a tricky one. I think a percentage is something that's very easy for patients or just individuals in general to latch on to because we use percentage in so many different ways. So it's an easy thing to grab hold of, or it's tangible, right? It's tangible for an individual
And we all know
to,
it. Yeah, we all know it's wrong, but it's probably close enough for consumers and for the general public. Like a speech banana. There's nothing
right.
on a speech banana that's right, not one thing. And yet we use that to communicate to patients. A grand piano is 80 dB at 2000 hertz. Really? Because I'm a musician. I got to tell you something. That ain't even close, you know? And a motorcycle is 90 dB at 8000 hertz. Are you kidding? Nothing on a speech banana is correct, yet we use that to try to make things simple. Why don't we just use percentage and get rid of
I
all
mean,
this stuff?
I don't disagree with you, Doug. I don't
All
disagree.
right.
Make it simple. This is, even if you just use a pure tone average, or if it's three frequency, four frequency, it's a single number. You have a 45 dB loss or 45 percentage loss or whatever that means or
Yeah.
whatever term you want to use, and then add to it. So that second number. So what would that second number be? Is it your signal to noise ratio loss? Is it your speech and
Triple
noise percent
digits.
correct?
Yeah. Well, there's so much information now showing that word recognition score in quiet isn't really telling us anything. And many people have proposed, if you do a Google Scholar search or a PubMed search, many people, by many, I mean 5 or 6 that I've seen in the peer-reviewed literature, that say, instead of doing, well, in addition to doing SRTs and word recognition in quiet, we should be doing word recognition in noise. And I like that a lot because I think that's where the most clearly 90% of the patients that we all see complain about speech and noise, yet very few of us test that. Now, I want to go back to something you said earlier, which is, you and I are speech and noise advocates, but then again, so is AAA and ASHA and IHS. It's in every one of their best practice models. And yet again, it's not being done on a regular basis by the majority. And I think that's terrible because when I go to see somebody for my vision or my hearing or whatever it is, and I tell them my problem is that when I'm reading a paper up close, I can't focus without glasses, and they give me all these distant things to do. We haven't addressed the reason I came in, and I think that this is a glaring mistake in many of our clinical protocols.
No, I completely agree. And it doesn't, what kind of trust is the patient going to have in you when you're not testing what they've complained about, right?
Yeah, fair enough.
And we know, you can have up to a moderate to moderately severe hearing loss and still perform in quiet above 80%. And
Sure.
so it just simply doesn't give you any additional information about your patient if
Yeah.
you are not addressing the complaint that they have or the problems that they experience, which is listening or trying to understand in background noise. And there's so many great tools for us to use that are quick and easy, right? I mean, the speech and noise tests that are out there that are commercially available are quick and easy. Like, for example, the QuickSend, the quick speech and
Yeah.
noise test. I mean, 1 minute per list. How
Yeah.
much faster can it get? You know?
Your point is very well taken. I won't go into too much detail there, but I absolutely, if you only had one test to do on a patient comes to see you and they say, Dr. Roup, I'm having difficulty understanding speech and noise. I'm 70 years old. I don't have any extreme noise exposure. And you only had one test that you could give them. What would that be?
Depending on their age, it would be a speech and noise test, and then depending on their age, I might choose the QuickSend as a quick
Yep.
screener, or I love the revised speech and noise test. I know
Yeah.
it's an oldie,
Yeah.
but it has the high predictability versus the low
Sure.
predictability, and you can use that as a really great counseling tool. Like, hey, look, these high predictability sentences, you did great.
And
With the low
that's,
predictability,
yeah. Yeah. And that's the revised spin, right? Yeah. And I'm blanking on who wrote that originally. It came out like in the mid 80s, I want to say.
so in the mid 80s, it was Bob Bilger
Oh, right.
who did the
Right.
revision of that. So it came out in the 70s, right? It was the 1977 was the original article
Yeah,
from
yeah.
Calico. And
Oh,
then
that's right,
Bilger did the
Calico. That was
revision.
the name I was looking for. Yeah.
Yep. Yep.
Wow.
So it's an old test. It's an old recording, and you can tell it sounds like it's an old recording, but I do like it. And you can still get it from your colleagues, right? It is not something that's commercially available, but you can get it. You just, email your colleagues and they'll send you the recording.
This goes back to there was a guy named Rush Hughes. Do you know where I'm going with
Yes.
this? So one of
Yes.
the original recordings that we used back in, I want to say from the 40s, was the Rush Hughes monosyllabic word test. Rush was the I don't want to say DJ, but he was the voice that recorded it, and it was a terrible quality test. And I remember Jack Katz telling me back in the I want to say the late 70s, early 80s, that you could still use it as a test of central function because it was so bad. And but if the patient could put it all together and make sense of it, they were probably fine. If the people couldn't, it didn't mean you had a tumor. Of course it doesn't, but it correlated with people who had other
Right.
retrocochlear stuff. And so bad recordings aren't necessarily useless. Rush Hughes. I haven't thought of that name in a few decades. Anyway, listen, I want to talk about there's somebody called Sarah Hazley. I remember her paper. I have it in front of me. The relationship between self-perceived hearing ability and listening related fatigue. And she covered so many cool things. Let me just, in her abstract, and I'll ask you to comment on this. Many adults experience hearing problems despite a diagnosis of normal hearing. An invalidation of self-perceived hearing problems can be emotionally distressing. Previous research describes a normal hearing test with perceived trouble understanding speech and noise as hearing difficulties. And then she goes on to say, recent studies investigated factors that contribute to deficits in speech and noise performance, a common symptom of HD. Um, Specifically, adults with poorer working memory and poorer extended high frequency hearing exhibited poorer speech and noise performance than adults with better working memory and better extended high frequencies. So I read this, I guess 2 or 3 years ago, and I was so impressed that what I thought, given the opportunity to speak with you, I would like to get your current thoughts on this. She concludes with, results from the present study suggest it is essential to employ more rigorous tests of auditory function than those that represent everyday hearing tests to more accurately assess an individual's hearing ability and validate their self perception of hearing difficulty, HD. Tell me your thoughts on that, because now we're 2 years later.
Yeah, 2 years later, so we're still looking at that relationship. So if I can just digress a little bit, Sarah's study was really based on a study that came out of National Acoustics Laboratories. So Ingrid Yiend in 2018 published a
Yeah,
study that looked at all these different factors that might predict speech and noise performance. So she had like over
right.
100 participants, and she sort of categorized them as, they did well in speech and noise or they did poor in speech and noise, and then what predicted whether or not you did poor with speech and noise, and it was working memory and it
Yep.
was extended high frequency hearing. So the working memory test that they used in that study was a reading working memory test, so it was
Right.
visual.
Right.
So what Sarah Hazley and I were working with is the auditory working memory test. So it's, and or if you're familiar with Sherry Smith's and Kathy
Oh
Pecora
yeah.
Fuller's
Yeah.
WARM, or the word
Sure.
auditory recognition and recall
Hmm.
measure. So we were using that. So yeah, I think we see in individuals with functional hearing difficulties, subjective hearing difficulties, whatever terminology you want to use, because there's 1,000 terms to
Yeah.
describe this population, but that working memory and listening related fatigue are symptoms of that hearing difficulty. And we continue to use auditory working memory as a measure of cognitive processing or executive function that is related to speech and noise deficits or difficulties.
Right. Right. And so when you talk about people with normal hearing who may have extended high frequency deficits, they may have working memory issues. To me, I tend to group all of these things into something other people refer to, and I hate to use a word that's not well defined, but I refer to these now in 2025 as subclinical hearing loss. The reason I do that, I think physicians are much more comfortable with that. Um, I think ENT, I think family doctors, I think GPs, internal medicine, when they see a test result, if it happens to be a patient they're also working with that says normal thresholds, it's so important to still document all this other stuff. And I think we can just start maybe calling it subclinical hearing loss, because I think when we use terms like suprathreshold hearing loss or central auditory processing disorder, or any of those things which are or central hearing loss, it puts it out in the ether for the mainstream. And I think that if we say subclinical, it seems more relatable to me. What's your thought? What's the best term to use when it's not airborne in speech, when it's not conductive or sensory neural?
Right. I don't know that I have a good answer because there are a lot of different terms.
Yeah.
Subclinical is something that I've seen a lot of, and I would argue that the way it's being used by Justin Golub's group,
Mm-hmm.
where it is thresholds 1 to 24 or 1 to
Yeah.
25, is, I would argue that that's a little too wide of a range. So subclinical, I think you run the same difficulty with subclinical that you do with slight or mild, right? So if it's subclinical, it's not clinically relevant, right? So I think you can run into that issue with subclinical. So
All right.
I
Good
guess
to
my
know.
answer is
It's
I
a
don't
good.
know if there's a perfect term.
Yeah, I don't think there is a perfect term, but I'm glad for your reflections on subclinical. I I think I struggle with the best thing, and I know that some people use the term auditory processing disorder to say it's not hearing, it's what we do with what we hear. And
Yeah,
that's
I think
that.
you have to be careful with that. I
Tell me.
study auditory processing, I
Yeah.
study binaural processing. I believe that people have processing deficits that you could categorize as disordered. But when it comes to this population, what you and I are talking about right now is this threshold elevation, beyond 15
Yeah.
dBHL, right?
Yeah.
And we know that, or I've had studies that have shown that if you have threshold elevation between 15 and 25, that strongly correlates with speech and noise performance.
For
Now, do you
sure.
have a speech and noise deficit? Maybe not, but your performance is definitely poorer than someone who has thresholds between 0 and 15,
Yeah. Fair
right?
point.
So I think
Fair point.
audibility or minimal threshold elevation matters when it comes to perception or auditory processing. So I
Yeah.
don't think it's as simple as saying that this is more of a central issue. The periphery and the central auditory nervous system works together, right?
Of course,
So
of course. And it's so hard to characterize these things because as audiologists doing comprehensive audiometric evaluations, we run into this all the time. And it's very hard to communicate it to the family or to the rest of the healthcare team without confusing people, because they don't know what a central hearing
right.
or central listening issue is. They don't know what auditory processing is. So I'm just trying to find a universal term, which obviously I did not find.
Yeah, we
Let
should we
me
should brainstorm this further.
Yeah, absolutely. So then you had this paper that came out about a year ago. It was May, June 2024 with Lander and Shang, I think, and you
Uh-huh.
writing about mild traumatic brain injury. I wrote a paper on that about 10 or 15 years ago, and I found it to be fascinating. But you went further in your conclusions, and you say the present study suggests conventional clinical audiometric battery alone may not provide enough information about auditory processing deficits in individuals with a history of mild traumatic brain injury. So tell me about that. I mean, I think you're exactly right. And I remember when I was at a trauma center, St. Louis University, I was there for 7 or 8 years or something like that. And you'd have people who would be in car accidents, or you'd have people who had fallen off a ladder, because we were a trauma center. And, sometimes somebody was clever enough to order an audiometric evaluation, but, it was really just 250 to 8K and temps, and let the ENT take a look at the ear, And I've always thought, well, that's not really a thorough, comprehensive, and more audiometric evaluation for somebody given a, traumatic or even mild traumatic brain injury. And yet, that's what we did.
Yeah, it's a fascinating group. I was involved. I have colleagues who were really interested in this in the veteran population,
Yeah,
with
of course.
blast exposure. But even just close head injury, we know has an impact on the central auditory nervous system, but it
Sure.
doesn't necessarily impact pure tone thresholds. So you look at that data that we published in that paper, it really the pure tone thresholds were all within the classically defined normal range. So nobody
Yeah.
had thresholds outside of that range. So if you have a patient coming in and they're complaining about hearing problems or speech and noise deficits, whatever their complaint is, and then you find out they have a history of concussion or brain injury, whatever that looks like, or whatever term they're using, pay attention to their complaints, because you need to do more testing than just the pure tone audiogram and words in quiet, because they're going to perform beautifully on those measures,
Yeah.
right? And I have colleagues in our clinic at Ohio State who have these stories of patients who make it to our clinic. So they have a history of brain injury, and they've
Sure.
seen 5, 6, 10 audiologists who say, well, you have normal hearing, but all they did was test their pure tone thresholds. And then they come to us. We measure their auditory processing abilities with speech and noise, with an auditory processing evaluation, or test battery, like the scan, which I think is a very easy, implementable test battery in a clinic, and they perform abnormally. And so their complaints are based on something real, right?
Yeah, but
Something is happening centrally.
Dr. Root, before I let you go, I want to talk a little bit about what is a difficult discussion for many professionals. So you have a patient who has subclinical or central or auditory processing, something going on, thresholds are normal. Would you or would you not try hearing aids?
I would. Yep. So I think that is a viable option. I think we can do that safely and effectively. And we have data to demonstrate that this population will benefit from mild or low gain amplification and the digital signal processing that comes along with advanced hearing technology. So absolutely, I think it is worth trying.
And in 2025, we have deep neural networks, we have fantastic noise reduction algorithms, we have beamforming, we have directional mics. We can actually improve the signal to noise ratio significantly for many patients, not all, but for many. And so I get this question when I'm out lecturing: are you saying that people with normal hearing should wear hearing aids? And the answer is no, nobody's saying that. What we're saying is people with auditory deficits, which by the way you have to test in order to find them, might improve their situation by having a better signal to noise ratio. And this is exactly what we've been doing, I think, since 1950s with children with auditory processing disorders, right? We give them an FM trainer, we give them a headset. Now we don't have to use quite so clunky tools, but we can give
Right.
them Bluetooth, we can give them digital remote mics, we can give them FM, we can give them, and sometimes we just give them hearing aids with very low gain, so you're not going to cause damage. But I want to
Exactly.
caution people, and I think you would share the same caution, that if you're going to do a low gain fitting for somebody with normal traditional thresholds but hearing difficulty, it's almost mandatory in my mind that you have to do real ear measures just to make sure that hearing aid is not
Absolutely.
malfunctioning and potentially causing a
Absolutely.
problem.
You have to do that. That is an excellent point, and I would never do a fitting like this without real ear verification. And I would also caution individuals to
Sure.
not solely rely on a prescriptive method or a prescriptive target, because most prescriptive targets like NAL or DSL, they weren't designed for thresholds,
That are
better than
normal.
20 dBHL.
And in fact, if you enter that into your software, it's probably not going to turn on the hearing aid. You won't get any gain at all.
It's minimal at best,
Yeah.
right?
Yeah.
So I think you have to decide what your protocol is. There's a couple of papers out there that have done it slightly differently, but I'm an advocate for measuring insertion gain. Know
Yeah.
how much gain you want to provide your patient, whether that is a flat 5 dB, like some or 5 to 6 dBs, like some research has done, or a more nuanced 5 to 10, depending on a little bit more gain in the high frequencies. But measuring insertion gain, I think, is a much better approach than relying on a prescriptive target that would be inappropriate for that audiogram.
I like that a lot, because if my insertion gain is 5, 6, 7, 8, 9, 10 dB, and I have noise reduction maxed out, and I have beamformers on, then when I am in a cocktail party situation, a restaurant, an airport, a group discussion, most of the amplification will be coming from the person that I am looking at, right? Because they're in
Right.
front of me, and most of the attenuation of noise will occur behind me, and mostly still for steady state noise, but some low rumbling and things will also be eliminated. The bottom line is, yes, we can make it clearer. And actually, people don't really want things louder. I know I don't want things louder. And I want it clearer. And it's the same thing in vision. People don't want bigger. They want it more focused. They want to be
Exactly.
able to read it up close and at a distance. And it's the same in hearing healthcare. So I think that I think that there's a long way to go before the entire profession starts to adapt best practices, because we're not even talking about anything extreme here changing. We're just talking about doing what's already in best practices. And I loved what you said, that we're not in charge of the pricing. We
Right.
are, right. And here's the thing. I mean, we're doctors, and are we going to do what the insurance company says to do, that what we can get billed for, or are we going to practice appropriate audiology and do what's in the best interest of the patient? I've been saying this for years, and I've been burned for saying it for years, but I don't really care how much we get reimbursed. Even when I was in my own private practice, the
Mhm.
reason my practice thrived is because we always did what was best for the patient,
There
and
you go.
made all the
There
difference,
you
right?
go.
If we just did what we could bill for in 92557 and um, not go beyond that, I don't think we would have been an outstanding practice. But I think we were an outstanding practice because we use comprehensive audiometric evaluation, which is best
Perfect.
best practice.
Perfect.
All right. Well, Dr. Rubin, it is always a pleasure. I'm so glad to see you, and I appreciate all the work you're doing in all these areas. And I will look forward to the next time. Maybe we can do something end of 2025.
Sounds great.
All right.
Thank you for
Thank you
having
so
me.
much. You're entirely welcome.